Then we now have Arne Decramer. Oh, you're okay?
I'm fine. So thank you. Happy to be here. Thank you for the organizing committee to give me the opportunity. And thank you for all of you standing and sitting brave till the end. It could be maybe an interesting topic because it's in something in between hands and the heart, and even with a bit of Dupuytren involved. So no conflicts for me. I'm working in a hospital. We are 17 orthopedic surgeons. And if you think about, we're doing 6 of us hand surgery. And if you think about the frequency of carpal tunnel releases in your own department, we do almost 1,500 carpal tunnels. So it's very frequent in every department, in every country, I would say, half endoscopically, half open technique. But then you get sometimes these questions of your cardiologist. And that triggered me one day when they ask you to do some biopsies. And then you hear about new medication treatments like tafamidis, recently reimbursed. And then you can have a beautiful joint venture in between a cardiology department and the orthopedic department, and specifically hand and plastic surgeons. For me, a real eye-opener was a congress, a bit like we see over here, in between patients and practitioners. And I was in Madrid, and I met over there Dr. Carlos Palau. And afterwards, you get triggered because we were the only 2 surgeons over there in an internal medicine congress. You can read about podcasts and publications coming up, and it's something we can't deny anymore. You will see more and more this pathology of amyloidosis. Already a long time ago, there was a description of taking tinosynovial biopsies, but nowadays, it feels more like a starfish problem. It's too overwhelming to consider the difference one can make with this. So amyloidosis is a disease where a protein misfolding disease gets down in multi-organ locations. And if you check, you have very different types of amyloidosis. The AL is well known, but this is more something to send to your hematologist, because this is really like a cancer that has to be treated with chemotherapy. But the most interesting for us is the ATTR, the cardiac amyloidosis. And this has a lot of orthopedic implications. Like seen over here, certainly the wild type, more the senile amyloidosis, has a big connection with carpal tunnel. And there's a hereditary form in some parts of the world, in the southern part of Spain, in Mallorca, and that's why Dr. Carlos Palau is very interested in that, with more polyneuropathy, so a more different type. If you check in carpal tunnel releases, there are some flowcharts already a long time described by Sperry and Donnelly. And if you check these 2 tires, if you have 2 characteristics, male above 50, female above 60, and bilateral carpal tunnel syndrome, these are most of our patients, maybe. And then, if you want to have both of the 2 of the first tire, or one of the first tire, and one of these other specific things you have to ask for in your consultation, then it should be a good idea to do a biopsy. What is a problem also, and certainly in Belgium, it costs a lot. It costs not for your patient, but for your hospital. So because of this cost, and because of some input of the cardiologist with blood markers and serum markers, we suggested to refine this algorithm and to get maybe higher diagnose of cardiac amyloidosis. So we checked and did a bit the same like the first flow chart, but with an extra characteristic from the 3rd tire. So increased troponin, NT-proBNP for heart failure, and immunofixation and the electrocardiogram. If it's positive, then you send your patient to a bone scintigraphy and referral to a cardiologist. As surgeons, you should read this article because they mention that in endoscopic technique, the diagnosis of cardiac amyloidosis could be less because of the small incision. This is how we do the incision and the biopsy. And I think in experienced hands and being aware of this potential pitfall, it should be comparable. That's what you get from your anatomopathologist. They check with the central Congo red and thioflavin images here if there is a positive amyloidosis. And then they go on with the immunohistochemistry. And you see over here the cost for your system. And that could be a problem, of course. So we tried to start up a prospective, with preliminary results, study, and we included 103 patients. Following the 2 tires and the extra 3rd tire, we had 44 not applicable for biopsy, but 59 had to do a biopsy, 27 were positive. So over here we have 45% positive biopsies with a Westermark classification as marked over here. The demographics and characteristics, I won't go into that because it's too small. The sample size is too small. You can't really conclude something out of these demographics and characteristics. But it shows something. And if you have this positive biopsy, then you should go for a bone scintigraphy and you give your patient the information necessary. It's all done by the surgeon. And then you ask your patient better to check with the cardiologist. Bone scintigraphy, a bit specific because you have to explain your patient with a positive amyloid biopsy, possibly for heart problems, that they have to do a bone scintigraphy. In our study, we only saw 2 with them positive on bone scintigraphy. That means that we catch these patients very, very early. So the cardiologic department was a bit disappointed. They said, yeah, they don't have any cardiologic problem. But that means that we take them very early and detect them very early. Because if patients are referred with already problems and heart failure, without treatment, they die in between 5 to 7 years. That's really published and clear. With the treatment, of course, we can help these patients. I won't go too deep in this different treatment options, but nowadays we have a stabilizer, and that's tafamidis. It's reimbursed, and that can be given to your patient. It's not my idea to give that to the patient, of course. It's your cardiologist who has to decide to give this or to start that treatment. There are upcoming projects. There could be a suppressor in the near future because it's in the liver that you get the synthesis of the amyloid. And also the elimination of the deposits could be a treatment. Even a combined treatment in the future will be interesting. So we are really in the beginning of a new area, and we need in our study, of course, more evidence. We need also a control group, like Carlos Heras-Palau in the NIH system. He takes in every patient a biopsy. And in revision surgery, I would suggest to think about these extra characteristics and to do systematically a biopsy if there's any characteristic from the heart with a pacemaker or a sudden arrest that these patients talk about. We started also a systematic review with one of our students at the University Hospital in Leuven to find out the correlation between the published different orthopedic manifestations and the risk or the percentage you get more risk to have an ATTR amyloidosis. And we also participate in a spinal canal stenosis because you saw that spinal canal stenosis is also a very frequent characteristic in these patients in the Alcatraz study together with the hospital in Bruges. Also very frequent in these patients operated for that. So a last small involvement maybe. There's only one publication by Barch and Caballero, and if you check this, they're speaking about ATTR and AL, 143 positive cases, and they found out that also 35% of them had Dupuytren. Of course, we don't have to dream on because diabetes is frequent, amyloidosis is frequent, Dupuytren's disease is frequent? Is this by chance, or is that some next future scientific work? So as a take-home message, I think we have to think and possibly universal, European, or in the whole world, to find out a good universal flow chart for the hand surgeon. It should be simple, it should be filled in 1 minute, clear for your surgeon and for the patient. We have to support, of course, this scientific work, and there's a couple of teams working on that, and to find out how we can share experiences and be aware, all of us, and share that message to our colleagues, orthopedic hand surgeons. Thank you for your attention.
Thank you very much.
Any comments? Gary.
Thank you for introducing us to an unusual disease, but it's really been out there now. It's interesting, and I have never made a diagnosis of amyloidosis myself, but in the last 6 months, I did 2 patients came with a request to have a biopsy at the time of their carpal tunnel, which is, so it must be getting out there, the word.
Yeah.
That's how it starts.
One from a medical doctor, one from a cardiologist, and I did both biopsies. I do all my carpal tunnels endoscopically and was able to get a nice biopsy to a both positive.
It will be a big issue in the future for certain.
Thank you for highlighting this. I'm part of that study with Carlos in the UK, and the paper is under review at the moment in one of the journals. The patients were followed up as many as could get to the National Amyloid Center with cardiac MRI, and the results are frightening. The number of patients who have cardiac involvement of their amyloidosis. So some of my patients now are on treatment for that. And it's a real sentinel, as you said. We're catching them really early. Mm-hmm. So it's a real opportunity, I think, for you to do a hand surgery operation and actually save someone's life or prolong their life, prolong their health. So really important. I just wanted to bring it back to Dupuytren's, because obviously we're talking about carpal tunnel syndrome here, which we all operate on. Oh, and by the way, the Tina synovial biopsies seem to be slightly better than the transverse carpal ligament. So,
exactly.
Yeah, I think that's going to be important, and we're going to be biopsying all of our patients, I think. Just to bring it back to Dupuytren's, what do you think that's real? That result? Should we be doing Congo red staining on all of our Dupuytren's as well?
I think we have to maybe check. Most of us, and I don't know if everyone, does a biopsy of your Dupuytren disease. If it would give the information and ask the question to your anatomopathologist to do the coloring for amyloidosis, maybe it could be a surprise also. And it's in our hospital. Mm-hmm. We mentioned it over there in Belgium. You have that low variable. That's very, very difficult to do in every carpal tunnel release. A biopsy in the spinal canal stenosis is no problem. But finally, if you do all the coloring, it costs you 130 euros in Belgium. But yeah, that's for your hospital. Another beautiful discussion will come up with the treatment, because the treatment also is 360 euro every day. It's a huge cost, and the question is, who are we going to put on treatment, and who will pay for that? But of course, it's preventive medicine. It can be a beautiful story.
Thank you very much.
Thank you.
Ilse, the floor is all yours.